Hello, everyone, and welcome to episode 133 of the Veterinary Behaviour Chat podcast. And today I thought we would go back to a topic that I have already recorded a couple of episodes on, but it's a topic that's really, really important and something that hopefully will be, getting more and more recognition, and that is canine cognitive dysfunction syndrome. Now, we do also see feline cognitive dysfunction syndrome, but I want to actually highlight a guideline that's come out very recently in December 2025, and that focuses mainly on canine cognitive dysfunction syndrome, although I think a lot of the principles that were found and have been highlighted in these guidelines can probably also be somewhat related to cats as well. So let me tell you about the paper, and obviously I'm going to put the paper into the show notes so that you can have a look at it and read through it if you want to. The paper was published in JAVMA, so that's the Journal of the American Veterinary Medical Association. And it's got actually some really, really big names in the authorship. So being a guidelines, basically the paper has been written by a working group. So a number of experts in the field have come together and have kind of looked at the challenges around some of the aspects of canine cognitive dysfunction syndrome. And we have internal medicine specialists. We have a couple of really great veterinary behavior specialists. So we've got Dr. Margaret Gruen, who is an American board certified veterinary behaviorist, and also my grand mentor, Dr. Gary Landsberg, who has done a lot of work in the canine cognitive dysfunction space. And we also have some veterinary neurology specialists. So Holger Volk, who is a German neurologist, spent a lot of time in the UK. And I actually was fortunate enough to spend my neurology rotation for my American residency with Dr. Volk in Hanover, which is where he's based now. So we've got some amazing specialists, but we also have some vets in practice as part of the working group, because I think that's where some of the challenges lie, is the recognition of canine cognitive dysfunction in general practice. And as we're going to hear in a second, the challenges in diagnosing the syndrome and especially sort of the early signs of. So what I've actually done is I've had a read through these guidelines through this paper. So the full name of the paper is the Canine Cognitive Dysfunction Syndrome Working Group Guidelines for Diagnosis and Monitoring of Canine Cognitive Dysfunction Syndrome. So it's a bit of a mouthful, but essentially, we've got a guidelines that are specifically focusing on diagnosis and monitoring of CCDS. So what I've done is I've gone through the paper and I've kind of picked out my 10 highlights, and I'm just going to take you through the 10 point by point, and hopefully by the end of it, you'll have a bit of a better idea as to what is in these guidelines. But as I say, if you want to go ahead and dig a little bit deeper, then I will link in the show notes the link to the paper, and then you can kind of read through it at your leisure, and have a look at sort of a little bit more detail, perhaps that I'm going to more detail than what I'm going to be presenting in these sort of 10 kind of points, I guess, summary points of the guidelines. Okay, let's get started. Point number 1 is a bit of a big picture overview. So, why did they kind of think about the paper or the guidelines? Sorry, why was there even the need for proposing a bit of a working group guidelines? And one of the things is that canine cognitive dysfunction syndrome is being increasingly recognized because we seem to be living with older dogs. So dogs are living longer. Our dogs are getting much older. I myself am living with a somewhere between 14 and 15-year-old dog. Our neighbors actually also have a 15-year-old dog. It's not uncommon these days to see dogs that are living to 14, 15, 16, maybe even longer. And I think as our dogs are living longer, we are potentially seeing more canine cognitive dysfunction syndrome, because we see previous research shows us that there's definitely a further deterioration in signs between the ages of around 10 to 11 and then the ages of around 15 to 16. So it's likely that we're seeing more of these older dogs in that sort of 15, 16, 17 year age bracket, and therefore we're perhaps seeing more canine cognitive dysfunction syndrome. Also, there's currently no standardized diagnostic framework. So we don't have a set of diagnostic rules or a framework to follow. And that means that probably canine cognitive dysfunction syndrome is still massively underdiagnosed in the general population. So I think there is more awareness around it. I think we're sort of seeing, more veterinary behavior specialists recognizing and talking about it. We're seeing more neurologists. We're seeing more vets in practice that have sort of particular interests in senior dogs, recognizing this more, but we don't have a standardized framework. So diagnosis can sometimes be challenging, and we'll talk a little bit more about that in a second. So we still have underdiagnosis, and then that leads to an inconsistency in approaches and in the care of these dogs. And so therefore, these guidelines proposes practical, clinically applicable guidelines for diagnosis and monitoring. So those are the two big pieces that they're sort of addressing in these guidelines. It's actually diagnosing the syndrome, and then how do we monitor it to see whether our treatment approaches are working, or, to see how dogs change over time in those latter years. So that's number one, a little bit about sort of the big picture. Number two is we're going into definitions here. What even is canine cognitive dysfunction syndrome? So it's defined as a chronic, progressive, age-related neurodegenerative syndrome, which is in many ways comparable to Alzheimer's disease in humans. And it's characterized by behavioral and cognitive changes that can affect daily life to varying degrees. And when we kind of in a second dive into sort of the disease progression, you'll see that there's definitely that to varying degrees is potentially quite important. So again, defined as a chronic, progressive, age-related neurodegenerative syndrome, comparable in many ways to Alzheimer's, characterized by behavioral and cognitive. So those are really important pieces. Behavioral and cognitive changes that affect the daily life of the animal to varying degrees. So that's point number two, definitions. Point number three is what are the key clinical signs? And this I've spoken about in sort of the other CCDS episodes that I've recorded previously. And that is our DISHA framework. So it's an acronym, DISHAA, that stands for the key clinical signs that we would most likely see in patients presenting with CCDS. So in our DISHA framework, D stands for disorientation. So those are oftentimes those dogs that kind of maybe get stuck behind doors or in the corner of rooms, or can't sort of find their way back from certain areas of the house. This is something that I've noticed in my own dog, Lexi, actually more recently, is that sometimes, she'll be looking for us at a different door. Maybe we'll be in sort of one of the rooms that has kind of access through a back door, but she'll be around the front door. So we have kind of an open space around our whole property looking for us when she perhaps exited the back door and knew that we were there. So disorientation is the D in the DISHA framework. The I is impaired social interactions, or changes in social interactions, and that can be between the dog and the caregiver, but can also be dog-dog, so other pets in the same home, or dog-cat, so changes in those social interactions. And that can be reduced social interactions, or that can be increased. So sometimes we'll see more clinginess, in inverted commas, if you like, but sometimes those dogs will also just take themselves away more and be less socially interactive, less social play, less coming up for physical interaction, those sorts of things. The S stands for sleep-wake cycle or sleep disturbances. So we might see more sleep or less sleep. We might see changes to nighttime activity or sleep patterns during the night. We might get nighttime vocalizations. So anything where we have changes in the sleep-wake cycle or where we see sleep disturbances. H stands for house soiling. And that can be seen as, I guess, a little bit of a sort of a wider implication of the loss of previously learned behaviors. So we could have a dog that, knows or has known for most years of its life where its toileting areas are. We go out into the garden to pee, or we go out for walks to eliminate. And now all of a sudden they've lost that learning piece, and they're now no longer able to remember where the appropriate toileting spots were. Now, I'm just going to touch on something here because this is where it starts to get challenging, and we'll go into this in a little bit more detail in a second, because house soiling can also occur in older dogs due to a number of other things. And physical health pieces are obviously huge here, whether that's, PUPD, so drinking more and therefore urinating more and therefore having more accidents in the home, or maybe it's pain, so therefore the dog is less likely to want to take themselves off to their known toileting areas. So the house soiling as part of the CCDS is truly a loss in learning, a loss in memory, so deficits around that learning and memory piece. It's not because of potential other causes. Then we have our 2As, which are activity changes. So a little bit like the sort of social interactions, we could have either decreased or increased activity changes, activity levels. So perhaps less activity, or sometimes maybe more activity, more pacing, that might come with that disorientation. So changes in activity. And then the second A, so DISHA has 2As at the end. The second A would be anxiety. So increased levels of anxiety, separation anxieties, often sometimes we see in CCDS. So increased anxiety levels or even signs of fear. And what's important to note about these signs is that they're progressive, they're variable, so they might not always present in the same way, or some patients might show some of the signs, some patients might show all of the signs, so there's a variability there. And early on in canine cognitive dysfunction syndrome, they can be really subtle, and that's where the diagnostic challenges come in. So, caregivers might notice something that's a little bit different, but maybe can't put their finger on it or pinpoint it. Changes are very subtle, or they're often brushed off as being to do with something else. And something you'll often hear caregivers in particular say, and some professionals, is they're just getting older, in inverted commas, where we know that old age is not a disease. So these changes can actually be due to true pathological and physical changes. And it's literally hardly ever or not they're just getting older, right? So that we have true disease processes underlying that. So that would be our point number 3, the clinical signs, the DISHA framework. And then point number 4 is disease progression. And this working group has proposed 3 stages of CCDS. The first one being mild. So there we would see subtle changes, often missed or attributed to aging. So what I've just spoken about. So the changes can be very low in frequency or in severity, and we still have pretty much, preserved function. So, normal daily function. We don't have any inhibition or loss of function in any way. So that would be stage 1, mild. Stage 2 is moderate, which shows or comes with signs that have a clear impact on daily life. So now we're starting to see some changes potentially in function, impacts daily life, whether that is less activity, less desire to walk, less social interactions. So we have a clear impact on daily life, and we're starting to now get to the realms of this requiring management. So we need to start really thinking about management strategies and how we can treat these patients. And then the final stage would be stage number 3, which is severe. And this is debilitating, affects basic functioning, and is starting to require significant support. So mild, moderate, and severe. Then number 5, we start to get into the nitty-gritty, and this is actually what this working group set out to do. So we're now getting into diagnosis. So how do we diagnose canine cognitive dysfunction syndrome? And it remains that this is a diagnosis of exclusion. So as I mentioned just now, there are potentially a number of other things that can bring about similar clinical signs or the same clinical signs, such as house soiling, activity changes, sleep disturbances, impaired social interactions, all anxiety. All of those 5 could also be caused by pain, chronic pain, acute pain, dental pain, musculoskeletal pain, visceral pain. So we have to be careful that even if the dog is presenting with 5 out of the 6 Disher signs, there could still be other things that are causing this. So it's a diagnosis of exclusion, and canine cognitive dysfunction, really importantly, cannot be diagnosed by a single test. Really importantly and really frustratingly, right? Like, we would love to have a single test to definitively diagnose or not diagnose CCDS. So diagnosis requires a thorough history and behavioral assessment, a thorough physical and neurological assessment and laboratory workup to try and understand whether there are physical health contributors. And we have to rule out some of these comorbidities such as pain, sensory decline, and systemic disease. So it's really important to have an understanding of that, but it's also really important to know that if we find any of these comorbidities, it doesn't mean that the dog doesn't have CCDS, but we probably need to manage these comorbidities or other factors first before we can definitively then rule in or out canine cognitive dysfunction syndrome. So absolutely, CCDS can be present at the same time that pain or other physical diseases can be present, but we have to be careful when we're diagnosing CCDS that we're taking that into account and that we're attributing or that we're looking at, how much of this or what proportions of this can be attributed to pain or other disease, and where does that leave us in our diagnosis of CCDS. Point number 6 is still about diagnosis. So they're proposing, this working group is proposing 2 levels of diagnostic certainty. So level 1 would be clinical diagnosis. So we've got these progressive Disher signs, as mentioned. We've got no alternative explanations after physical workup. And we've got perhaps typical diffuse forebrain signs on a normal neurological exam, on a normal neuro exam. So that would be our level 1 of diagnostic certainty, which is all clinical. And then we have level 2, which is then advanced diagnostic strategies that can include imaging. And that would include MRI evidence of cortical atrophy, amyloid depositions, myelin loss, neuroinflammation, and amyloid angiopathies. So we're seeing true imaging signs or imaging evidence of CCDS. And at the same time, we've got normal cell counts on CSF analysis. So CSF is cerebrospinal fluid. So that's the fluid that surrounds the central nervous system. And we can tap some of that fluid and examine it for signs of inflammation or cells, which is indicative for other things. So other disease processes, neuroinflammation of other origin, for example. So if we have normal CSF analysis where cell counts are within normal limits, and we've got evidence on MRI of changes that can be associated with CCDS, then that somewhere gives us an indication of diagnostic certainty. So that would be level 2. Point number 7, so that was point 6, 2 levels of diagnostic certainty. Point number 7 is the role of the caregiver input, which is so important here because it's the caregivers that are going to give us insights into that dog's daily life. And they can be so instrumental in monitoring over time, seeing whether, the stages progress from stage 1 mild to stage 2 moderate. And that can then really help inform us as clinicians in terms of treatment plans. So caregiver questionnaires, are really, really important. And I guess the most commonly used in the questionnaire that I use, just because it relates also to the clinical signs, is the Disher questionnaire. And that is something, that caregivers also find really easy to fill out. And I have all of my behavior patients over the age of 8 fill out a Disher questionnaire every 6 months routinely. So Ben knows. We just send it to them. If they're sort of first initial consultations of senior patients, then they all, as part of their initial questionnaire and their intake questionnaires, they all get a Disher questionnaire to complete. And then anyone that perhaps crosses over into that sort of above 8 years of age range then gets a Disher questionnaire, and that's repeated every 6 months. We have a number of other questionnaires. The KDs might be another one that you're familiar with. But whichever questionnaire you choose, it depends on your comfort levels with it, your familiarity with it, and how you feel the caregivers, I guess, cope with them. So caregiver questionnaires are essential, and they are best used for monitoring that progression over time piece. So as I mentioned, just so that you can compare scores from today to 6 months to 12 months to 18 months to 24 months from now. And they're really good for detecting subtle early changes. So again, those behavior clients or behavior patients of mine that, I see for the first time at age 8 or more, it can be really interesting to see whether we have any subtle changes. And then, of course, we have to go down the route of excluding all other potential causes. But it's really interesting sometimes to see how much CCDS can contribute to behavior presentations. So questionnaires, great for monitoring progression over time, great for detecting subtle early changes, but not reliable as a standalone diagnostic tool. So we have to always, go through all of the other diagnostic processes that I just mentioned before. So that level 1 clinical diagnosis piece, which are, the progressive Disher signs, no alternative explanation, and then a neuro exam might show us some typical diffuse forebrain signs. So those are the questionnaires and the importance of the caregiver input, but it's really, really important, and also mentioned in the guidelines here, that caregivers may show responder bias, right? They might answer the questionnaire with a bias towards or against cognitive dysfunction. And again, we need to be really mindful when we're evaluating the questionnaires of this influence of the comorbidities. So when caregivers are scoring really highly, perhaps on a change in activity levels, then we have to be really mindful that we're thinking, as we as clinicians are looking at that questionnaire, well, what's that change in activity levels coming from? Could there be pain present? Are there other things? Is there other neurological disease going on? And how does that fit in with our diagnosis? So that's point number 7, the role of the caregiver input and the questionnaires. Point number 8 goes back to imaging and pathology. So kind of dives a little bit deeper into what we might find on some advanced diagnostics, especially imaging. So MRI findings can include brain atrophy, which is a key feature, hippocampal volume loss, microbleeds, white matter changes, that kind of, I was going to say neuroinflammation, but that's actually histopathological. Okay. So brain findings, brain atrophy, hippocampal volume loss, maybe microbleeds and white matter change. And then histopathologically, we might see amyloid deposition, which again is really typical for canine cognitive dysfunction and is also seen in human Alzheimer's disease. Neuroinflammation and myelin loss, also something that we can see on histo, but obviously if we're looking for it histopathologically, this is going to be post-mortem, right? So it's a different type of diagnosis. It's a post-mortem diagnostic process. Otherwise, we'd be needing to take, cuts of brain sections to be looking for this. And then, however, some of these can overlap with normal aging processes, which again brings us back to this sort of diagnostic challenge. So we can see that diagnosis isn't easy, especially that kind of definitive diagnosis, because histopath can only be done post-mortem. MRI changes might overlap with normal aging processes. How many caregivers are going to consent to an MRI of their aging dog, just in inverted commas, to see, potential changes? And that again comes back to that importance of that clinical diagnostic process and understanding, that diagnosis of exclusion and the 3 stages and the clinical signs and so on and so forth. Point number 9 is a bit of a summary before we go on to the final point, number 10. So point number 9 is a bit of a summary. So early signs are subtle and non-specific. So summary of challenges, I guess. Early signs are subtle and non-specific. The difficulty, again, in distinguishing between normal aging and true pathology. We've got a lack of standardized biomarkers. We've got a lack of practical cognitive tests, specific cognitive tests for in-clinic use. And we have this really high impact of comorbidities and caregiver bias and perceptions. So there are a number of challenges in diagnosing, but I think if we're aware of these challenges, it helps us in our diagnostic process, and it makes us feel a little bit more confident because we're aware and we're able to understand the clinical picture better in light of these diagnostic challenges. So that would have been point number 9, our summary and diagnostic challenges. And then point number 10 is really nice because it gives a bit of an indication of where future directions might be lying. So future directions could include the development of blood and CSF biomarkers. So we might in the future have a blood test or a CSF tap test that we can look for changes that are diagnostic of CCDS. And in particular there, we could be looking for things like amyloid or neurofilaments. So looking at true biomarkers, that can help us in that diagnostic process. And then the other thing, which I love, would be simple cognitive testing tools that can be used in practice. So diagnostic screens, so asking the dog to perform certain cognitive tasks in order to be able to evaluate how advanced cognitive changes might be. And we've tried using some of these in practice before. I know I have tried them. There are a number of sort of cognitive tests that you can do. You can ask a dog to learn a really sort of simple task, maybe a nose target. You can ask them to identify, like the 3-cup test, have 3 cups and ask them to identify under which cup the treat is. Or you can ask them to gaze at you for a prolonged period of time. But none of those are necessarily specific to CCDS. You could argue with the finding the treat under the cup, how much is smell involved there. So, we're testing sensory abilities at the same time. In terms of teaching them an easy exercise, we have to be really cognizant of what their prior learning history is, if that has somehow been poisoned and they've actually experienced fear around learning in the past because they've worn shock collars or whatever it might be. So, and the gaze test, again, where, that could be influenced about human sociability preferences, or like there are so many things that can potentially influence some of the cognitive tests that we've maybe been using so far. So having a really nice, simple cognitive test for practice would be just wonderful. So amazing. And then the final sort of piece of future directions, again, comes back to the need for standardized diagnostic criteria. So, the Disher questionnaire or the Disher, I guess, clinical signs and the questionnaires that we have are all well and good, but they're perhaps not standardized and validated. And then we need better longitudinal, so over time monitoring tools, better than perhaps the questionnaires that we have right now. So that was a bit of a summary of the guidelines, the working group guidelines. I love these because I think they summarize so nicely the challenges that we face as clinicians in practice. And I'm super excited about the potential for future developments. I mean, how awesome would it be to have, a blood or a CSF test for CCDS and even better, you know, a simple cognitive testing tool for practice. I mean, that would be just great. But yeah, I hope you found that useful. I just thought it's such an important topic. It's something that I see more and more of, or that I'm including more and more in my screening tools, especially for my older patients. And funnily enough, I am seeing older patients much more. And some of the challenges that we have at the moment, you know, that it's not a perfect system right now. Diagnosing isn't easy for all the reasons that I mentioned, you know. Even getting those patients in front of you, because caregivers actually see this as a sort of a true disease, and then all the other challenges that we've spoken about. So there's a deep dive, well, not a deep dive, a little bit of a summary, the 10 sort of highlight points, I guess, from the working group paper. I will link it in the show notes. Have a read of it yourself if you're interested. And yeah, I hope you found this useful. And I very much look forward to seeing you next week for episode 134. Bye for now.